Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Okay, it's 9 o'clock. I guess we can get started, John, with the articles, which well, this was a very interesting article that one of the few articles that I've read that rewards the people who stick with their CPAP therapy because it 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 points out the many ways in which your brain is protected by you having more oxygen and allowing your brain to recover from what happens during the day before you go to sleep and how uh, taking your nightly CPAP does marvels for the rest of you. And it's not often that you find an article that really puts into perspective the importance, if you have obstructive sleep apnea, of using the CPAP nightly. This article talks about the negative effects of not having oxygen, uh, how it affects your brain, how it affects your blood pressure, how it affects so many different components of your health. And uh, putting on the CPAP and using it every night uh, takes care of the blood vessels in your brain and helps your central nervous system. And it is very worthy. It's not too often that people appreciate the fact that the damages of not having a good night's sleep. And when you're continually battling for oxygen, uh, this causes all kinds of negative consequences with acidosis and other things that don't allow you to get sleep, and you're fighting for breath almost every minute of the night. And this shows how that decreases the number of bleeds that you have in your brain and how it allows your brain to heal. And that's among the many important things that contribute to good health. And this is that's probably one of the first articles I've seen that actually goes step by step to help you appreciate the merits of CPAP uh, if you have obstructive sleep apnea. And of course, if you don't have a partner, you could have sleep apnea and not know it because you don't know if you're snoring if you live by yourself. So if you have a partner, you'll know because your partner will let you know if you snore and because you may keep your partner awake. So any comments on the merits of CPAP? John and then Darryl?
Yes, I've been using CPAP now for probably 7 years, 6 or 7 years, and I have mild obstructive apnea. Uh, my son has severe apnea. In fact, he just did another sleep study where they kept him overnight, and
Mm.
he was so bad. Uh, they're going to have to add oxygen, I think, to his CPAP machine. But I was
Wow.
just wondering, how many on the group have CPAP or have used it? And I sometimes I wonder if it's worth it, but after reading this, I see yes, it's definitely worth it.
Yeah, it's a lifesaver, actually. Yeah. Okay, thank you for sharing, Darryl.
Yeah, for those that find the CPAP uncomfortable, there's some alternatives. I hear them advertise a device called Inspire, but it's supposed to be maskless. And
Oh yeah,
then,
that requires a surgery. Right.
oh, it does. Okay.
Yeah, it
Then there's
requires surgery.
oral appliances that dentists can make that move the jaw forward and keep the tongue in place. That's a possible alternative to CPAP.
Right, and there's another medication that's coming out soon that alleges to be uh, allows you to overcome the oxygen deficit, but that's still experimental. CPAP still is the gold standard. Yeah. Thank you for sharing. Anybody else on the call that is also on CPAP? Sounds like you're the Lone Ranger, John.
Uh, I resemble that remark.
Uh, okay. All right. But this is a great article to put things into perspective. This is an interesting article that reminded me of John Buchanan because he's always asking how much things cost. And this article talks about four new drugs that are excellent but are very pricey. And it goes into detail in terms of talking about the treatment for motion sickness, treatment for pain, because there's a new pain medication that's not opioid, and then treatment for rashes, and all of these are great drugs that are very important. But for example, the antibiotic is going to cost $2,000 for a 5-day
Ooh.
course,
Mm.
which is for 5 days. That's expensive. And then the medication that takes care of the rashes is also expensive, costing about 30,000 for a 30-day uh, period, almost $5,000. Although all of the monoclonal antibodies that they use are expensive anyway, but this is even more expensive than that. And then, of course, the drug that I think is maybe even greater game changer is the non-opioid medication, which would eliminate the drug addiction, some of the drug addiction problems that we have, and uh, so that, and I think it goes into detail in terms of how much more each of these new medications cost. Now, uh, all of them are not uh, totally FDA approved yet, but it's expected that they will be. Uh, but looking at some of the prices that are seen on these articles, it is pricey. But uh, when your health is concerned, I guess uh, pricey is not, may or may not be an obstacle. When you're talking about $5,000 for a 5-day drug, that's pretty pricey. Uh, $2,000 for 5-day courses. But now the new opioid is worth its weight in gold, though when it's going to be approved, remains to be seen. But that would be a major boon to eliminating the hydrocodone, the oxycodone drug, which is a great source of addiction. Uh, it's probably one of the commonest drugs that people use, and that begins the addiction issue. Uh, but uh, uh, but we're getting a lot of new drugs, but the new drugs do have a price uh, that you will have to pay for these new advances. But with most of the new advances, after 6 months or so, or a year or so, the prices tend to go down. Uh, but certainly that initial period in which they're very costly uh, may result in people not taking advantage of these new drugs. But it's good to know that motion sickness it's interesting. There's so many different ways of treating motion sickness these days. And they even have a wristlet that you put on that address motion sickness as well, which may be the cheapest of all if it works. Any comments about these four new drugs that have a clear benefit uh, when they come to market, although they are very pricey? Probably no comment because they're not available yet. And when they become available, I guess we'll be able to talk more about that. But it's good to see that the research is still going on in spite of the administration's uh, efforts to block so much research. Still, we have a lot of research that's making a difference. We're getting close to the point now. Plus, when fall comes, and we'll have another election of the parties. It's going to be interesting to see if that will affect any difference between the current administration, and the whether the House or Senate or Senate will change. Uh, no, there's a great hope that it will change, but time will tell. Okay, if there are no other comments about these great advances, go to the next one. This is an article that talks about the fact that when you have a weekend and you try to catch up with sleep, this may interfere with your blood sugar controls. And this is dangerous. And they talk about if you're behind in your sleep, that you can catch up, but once you catch up, overdoing it can cause more harm than benefit. And so the bottom line is you try to get your 7 to 9 hours of sleep every night, and uh, waiting to catch up on sleep over the weekend alone itself is not alone the answer. If you overshoot, if you really just actually catch up, it's good. But when you go beyond that, they're suggesting, therefore, that too much sleep is harmful, and that its impact upon the hemoglobin A1C is associated with peril. And it's an interesting balance that you have between getting the 7 to 9 hours that you should get and then overshooting. Uh, particularly if you are diabetic. Any comments or question about this interesting article that talks about the perils of getting more than the 9 hours of sleep that's recommended? The perils of not getting enough sleep are pretty clear and evident, but uh, there are very few articles that really talk about the negative consequences of getting more than 9 hours of sleep a night. And this is one article that does so. Let's go to the next article, and there's no question. This is an interesting article because it points out, you see people wearing masks all the time, and sometimes you may wonder why they're still wearing masks when the flu and all that is out of season. And this is an article that looks at the viruses that are present in the hospital, and it points out that the masks actually helps protect you from these particles that are in the hospital, uh, especially if you go to visit, and they will uh, could make you sick. And wearing a mask does. Uh, and of course, you know that there are countries like Korea where people wear masks because of the pollution. And there's evidence that we have a lot of pollution in the United States that wearing a mask might be helpful. So that's and this study just uh, identifies the fact that viruses and bacteria are present, and wearing a mask may be helpful. Um, it's one of the first studies I've seen that identifies that the merit of actually wearing a mask because there are infectious particles that are present that a mask would help eliminate. And then, of course, if we had high efficiency filters, that would do the same thing. But if you don't, then a mask would be desirable. And in our country, which because of many of the fires and other things, we have a lot of pollution. Uh, People who wear masks may be doing the right thing. Any questions or comments about the air pollution that we have and why wearing a mask can be a benefit? You can imagine if there's pollution in the hospital, uh, you also have a lot of pollution outside of the hospital in the streets and also in some of our homes. We don't have uh, efficient ventilation. John?
Yeah, I have a friend that works at Goddard Space Flight Center for NASA, and he just told me that they have on average, two rocket launches a day. So
Really?
can you imagine all of the pollution from those
Yeah.
rockets
Yeah.
putting satellites in orbit
Right.
every single day, and all the junk that's floating around our planet? Uh, you know, a lot of people don't like cartoons, but I like cartoons. If you ever get a chance to see the art, the movie called Wall E. It'll really make you think about how we are treating our Earth. Uh,
What's the name of it?
Wall, WALL dash E, the letter E.
Oh,
hmm And
hmm.
it ends up where everybody has to take off from the Earth because they can't grow anything else on Earth. Everything's artificial and robots are taking over. So,
Wow, amazing. Dr. Perez, welcome.
Good morning, family. Wow, I love that movie, Wally. And I was raising little JC. I think I must have seen it at least 10 times. Um, it's the principle is so important. So important. I'm glad to see I'm not the only one, but it's worth watching. That should be an assignment for the transplant support group.
I never heard of the movie. Hmm.
yeah,
Yes,
I agree
children.
100%. 100%.
Yes, very good.
Hmm.
Even a little love in there, right?
Hmm. Wow, never even heard of that movie before. Hmm. But how old is it then? About 20 years old?
Now, it came
It's
out
not that old. Let's
it
see.
came,
Well, it's at least. It's not that old. Maybe closer to 10.
Oh, not at all.
Yeah, it's not that old.
Hmm.
It was definitely marketed, of course, to children, but just about our laziness about the things that we do know and that we're not doing anything about,
Hmm.
and our responsibility to take care of the earth.
Hmm. Thank you for sharing. Okay, guess we can go to the next article. Oh, this is a very interesting article that talks about taking care of type 2 diabetes and how we need to be uh, stick closer to keeping our hemoglobin A1C at 6.5 or thereabouts, uh, emphasizing the avoidance of complications of hypoglycemia as well as the complications of not having the blood sugars controlled, and then uh, how uncontrolled diabetes leads to many other complications that result in loss of limbs and heart trouble, strokes, and kidney failure. And of course, the one thing that we don't like to see is hypoglycemia because that can kill you as well as hyperglycemia. And sticking close to the 6.5 level is what this article recommends, which isn't always easy to do, but it seems to be worth its weight in gold. Uh, Unfortunately, you find many diabetics who have hemoglobin A1Cs in the ranges of 7 and 8, but that is not uh, what is desirable. Uh, and most feel that you need to at least be below 7. But as I look at hemoglobin A1Cs of of some of the diabetics, they not too many of them are actually in the 6.5 to 7 range. But those of us who take care of diabetes recognize the perils of uncontrolled blood sugars, which affect the blood vessels. Dr. Perez?
And you would think with this article, it wouldn't be difficult to get a CGM, con,
Well,
con, continuous glucose monitoring. But it is very, very difficult unless you are seeing an endocrinologist or you have someone who's going to advocate for you to be able to get this without being on insulin.
yeah.
And
Yeah, yeah.
so we have we have this scientific evidence, but yet we tend to move in the opposite direction. And go ahead.
That's so true. That's so true. Because we're seeing more and more articles that are identifying the value of continuous glucose monitoring, but we're not making it easy for that to occur. How do you think it's accomplishable? Because
Education, making
education of
sure making sure that patients know how important it is, and that it's part of standard of care. It
I don't
should be
agree with you. I
okay.
think I think education of the doctors is what the problem is.
Oh,
Because
really? Why?
yeah,
Why?
I think because if the doctors don't educate the patients, then the
Oh,
patients
okay,
don't know.
okay.
So, and I think that many of the doctors have a, look and see attitude rather than making it mandatory or important. And they just mention continuous glucose monitoring and move on. They don't re-emphasize. I think a lot of the responsibility should be on the physicians to better educate the patient. So, in a way, I'm agreeing with you that it's education. I'm just saying that that education should be focused on the doctors uh, educating their patients better about the importance. Of course, they can't do this unless they are able to make it easy for the patient to get continuous glucose monitoring. Luke?
Absolutely. And I agree, and I would have to say some of the administrative quote unquote stuff that has to happen in order for a patient to get anything. Um, there seems to be so many steps necessary if a treatment or a prescription is rejected by the insurance company.
Yeah. Yeah.
That can be hours on the telephone,
Yeah. Yeah.
back and forth and emails and so only the strong, only the ones that are dedicated are gonna bother.
It's a very good point you're bringing up, though. And so John Buchanan, then Darryl.
You know my question. How much does the CGM cost?
If
Uh,
you are paying for it, Costco has the cheapest one, which is about $100 for $100 for a prescription for 2 weeks, because it's now up to 15 days. Both Dexicom and Freestyle Libre. Freestyle Libre, I think Dexicom must have some kind of um, agreement with the federal government. And I think they switch off every couple of years. So Dexicom is much more out of pocket expensive than Freestyle Libre. But
Uh,
that's how much it is.
Another question. Is that the round thing you see on people's arms or
Arm,
stomach?
yes. Uh-huh.
And is that surgically installed?
Oh no, you just it's kind of like it sticks on there.
Oh,
Um, it hurts a little bit when you put it on. It's like a little, but it's not as bad as a finger stick all the time.
mm.
And then with the 15-day, it sends your glucose to your phone every minute. The other one was every 5 minutes, but this one you will get a response every minute. So that's very close to real time. And it has definitely made a big difference in how I care for myself. You know, you can tell whether it's going up. So that's not a time to take a bite of a cookie. You know what I mean? But it also my issue has been hypoglycemia
Mm.
and without medication where which is a result of high glucose that then becomes very low. Um, so you know, knowing where I'm going versus um, the feeling of hypoglycemia can be very scary
One, one,
because
one more question. Can you exercise with that on? Can you swim or
oh, you
run
can do all of that, and I bathe daily
with, with it on? Okay.
with it on, and then they also have some things, some extra patches that you can put over it to keep it on, but it has not been a problem for me. I'm surprised how well it sticks.
Thank you for sharing. Darryl?
Yep. I'm reading that Medicare Part B covers CGM systems for Dexcom and Abbott classified as durable medical equipment. Uh, is anybody familiar with that if they're getting coverage through Medicare Part B?
Yes, and that is the problem because it's durable medical equipment. It's very difficult. That's where you would normally go for a wheelchair or uh, some kind of device like that, as opposed to going to a pharmacy. So many of these other companies that specifically deal with diabetes, like monitors and um, um, pricking things, and they are the ones that kind of have that make it much easier. And so, even though it's durable medical equipment, you have to have an endocrinologist. You can't be managed simply by your primary care provider. So, for well over a year, fighting with CMS because I'm not on insulin was a difficult task to finally get a CGM that I wasn't paying for directly since um, I'm now a seasoned saint, so to speak, on Medicare.
Thank you for sharing. Catherine?
Good morning. I was just going to say I'm diabetic, but my endocrinologist told me that because I'm controlled and I'm not on insulin, my insurance would not cover that device. So I can't use one. My husband had one, but his was covered by Medicare because of his levels. But when I asked about it, he told me they would not approve it. I would have to pay out of pocket for one. So it is still a problem for people who aren't on insulin.
Thank you for sharing. That's, yeah. Hmm. So that sounds like an enormous problem, you know.
And a problem that I think that we need to change because we know what a big difference it makes. Just like we know that with watches and cardiovascular disease, a smart watch and a and and um and its availability. I mean, it makes a very, very significant difference in someone's economic class. And I don't think that's fair. The research, a lot of the R&D is done on public money. And then only the rich get to, you know, appreciate it. No, I think that it is a device. We are disproportionately impacted by diabetes. I know the studies are there that shows that people who monitor themselves on a regular basis, we talk about taking your blood pressure all the time, and now I think that's also available on Medicaid, on Medicare, that you can get a sphygmomanometer. So we know that these devices, we know that this intervention makes a difference. And our taxpayer dollars are going to build a freaking ballroom. No, I don't think so.
Yeah. What do you mean? No, you don't think so? You know so.
No, no, I don't think my tax dollars should be going to a
It's
ballroom,
going
and I
to
don't
it.
have anything to say about a CGM. No. Take
Just
it
a
to the
billion
streets.
dollars. Just a
Take it.
billion dollars. They
Uh,
only asking a billion.
okay, Catherine, did you have another question, or did that answer your question? Not Darryl.
Okay. CGM systems are widely available and increasingly used across European Union countries. So you may not ever get the job done in the United States, where the goal is to save money rather than save lives. But it's another reason why you might consider going somewhere else.
Okay, thank you for sharing. Once again, the facts are there. The question is, what else can we do about it? Uh, and we wonder why our lengths of lives are shorter here than other places when it's quite evident why. Any other comments or questions about the very important discussion that was just had and the role of continuous glucose monitoring, which is uh, which is rationed. You'd have to call that rationing. Okay, let's. Any other comments? If not, we go to the next article, which is a philosophical article. It says a provider provides, a physician decides. And this is an article that says that physicians are more than providers, that they educate and empower their patients to make the right decisions about their health. And so that to be called a provider from this writer's perspective is an insult, and that we are practicing an art and a science that requires us to have particular training to give patients advice and recommendations, and the patients can follow them if they wish. But it's up for us to give them that advice, and that's the difference between a provider who just provides what the patient may ask for and a physician who helps them make the right decision about what they should be getting. Uh, and that's in essence what this article is really all about. Any comments from any of you relative to the difference between a provider and a physician? Or are physicians becoming more providers than they are physicians? That's the question. Lucy?
That is probably a question we could have a whole session on as we as we talk about multi-level providers of care and physicians and what is now the responsibility with a totally different um, years of training and experience for the quote unquote title. And it's very, very different. And uh, seeing that there has not been a significant increase in the number of Black physicians in the last 60, 70 years. In fact, we're projected to be lower than we were by the time we get to 2030 than we were at the turn of the century. So with it's a significant discussion. We have my primary care provider, um, a physician, has gone to concierge medicine. And the rest of her practice is taken care of by nurse practitioners. Nurse practitioners now that are called doctors because they have a doctorate in nurse as a nurse practitioner. The same is true of physician's assistants. And the difference in, I think, the philosophy of medicine and the years and experience that the person would have at the time that the title is given is significantly different.
Oh, by the way, I meant to tell the group that Patty DeLone had successful open heart surgery and is recovering satisfactorily. So uh, the Lord is answering our prayers and she's doing well. So just to let you know that she is recuperating at home now and doing well. Any other comments about the provider physician discussion? Darryl?
Yeah, my comment is that, I'm just remembering John Tatum's last years where he had a primary care physician and several specialists. And, the title for the group of physicians or providers would be his care team. But, okay, it's a team, but does a team ever talk to each other before? And if do they ever talk to each other, and who's the quarterback? It seems that a lot of times you get medication conflicts of doctors prescribing drugs that don't work well with, don't play in the sandbox well with other drugs. Does a team ever talk? And is there a quarterback? And should the quarterback be the primary care physician?
That's a very good question because I don't think there ever was a team. But if there were a team, then you would need to have a quarterback. But I never felt that he had a team of doctors. A team of doctors suggests that they are working together as one, and that was never seemed to me to be the case. Carol, you had a comment.
No, there wasn't a team of doctors. And even in the hospital, sometimes he goes in the hospital and they'll change the drugs around altogether. Then they say always refer to the primary care. And whether it came to the kidneys or the liver or even the eyes, nobody ever talked with each other. They just say, go to the primary care. And he was supposed to go and figure out all the medicines. One time he was prescribed one medicine and we went on a Friday and he called us on a Monday and said, don't take that medicine, which was a little bit too late. But I don't ever remember that they even have time to talk to each other because he had so many doctors. But Dr. Callender, you were one of the ones that he referred to, but I don't think you ever talked to any of his doctors.
No, there's no team.
There's no thing.
There was no team. The point that Darryl was making is that you would have hoped there would have been a team that was coordinating his care, but there did not seem to me to be any evidence that there was a team. It was all individual doctors doing different things and without any coordination. That was my overall perspective. Dr. Perez, you had a comment?
And we're moving more in the wrong direction with hospitalists. Because with a hospitalist, if you're in the hospital, then there is a doctor who only sees you while you're there in the hospital. There's no communication with the doctor that you see on a regular basis, be that your primary care provider or a specialist for a particular when I'm having trouble with my blood sugar, the person who is really should be the head of the team is the endocrinologist. And so especially now with hospitalization, these specialists don't even communicate with the team that's taking care of you while you're in the hospital. And so many patients leave the hospital on a whole new regimen of drugs, come back, they're taking their old drugs and the new drugs. They don't know how many of the drugs are the same. It is a disaster, an absolute disaster. And nobody wants to be the quarterback because the quarterback is the person who's taking care of all the administrative stuff with the insurance companies that don't want to pay for anything. So it is a major problem. It is a significant problem.
Carol, you had another comment?
Dr. Perez, I need to give you a trophy. You hit the nail on the head. I came across that so much. And then one time John was in the hospital and one of his physicians was there and they said, John, what are you doing here? Then they looked over the orders and she almost, not in front of me, but I heard about it, had a fight with a team of doctors of what they prescribed and told them they should not have prescribed that. And this is the route they went. And the nurses didn't know what to do because she had been providing with his kidney doctor, and the team, which was an educational team, they're going around making these opinions and not based upon his history. So you are absolutely correct. But it leaves us as the patients and the caregivers. It's just the hospital is supposed to take precedent over what all the other doctors have said.
Okay. Darryl, you had a comment?
Yeah, I just put in a search question that said, can you ask your primary care doctor to coordinate with specialists? And it says, yes, you absolutely can and should ask your primary care physician to coordinate care with specialists, acting as a quarterback of your health. Your primary care can ensure specialists receive your history, review test results, and align on treatment plans to avoid fragmented care, and that you can request a formal referral. Even if your insurance does not require one, a formal referral ensures your PCP sends relevant records and clinical information to the specialist. You could also ask that the specialist send notes back to your PCP after the visit. If they're all in the same hospital system, that's easier to share records with each other. And so, I guess that's something that we should proactively do if you're working with a team of doctors. Well, I'm sorry, didn't mean to say team, working with a group of doctors.
Yeah, well, see, the biggest problem is that when you are a transplant patient, many of the so-called specialists and other doctors become afraid of how to handle you. And as a consequence, the team effort is lost. And that's why, for the most part, the best way to handle a transplant patient is to have the transplant person coordinating all the care, uh, because then you have a team. But if you have a team of specialists in which the specialists consider the transplant as a special situation and they aren't comfortable, then you don't have a team, and then you have what Carol and Lucia are calling a disastrous situation in which there is no quarterback, there's no team leader, and there is no team.
And given this is Mental Health Month, I know I'm just jumping in there. If you have a psychiatric diagnosis on top of all of this, oh my gosh.
Well, to me, I don't think that's a problem. If you really have, see what Darryl mentioned, which is missing, is the quarterback. So if you have a quarterback, then it's not a problem. But if you don't have a quarterback, then you have all these pieces dangling out there all by themselves. And without that coordination, you don't have the accountability and the responsibility for that patient that you need to have in order to take care of a complex situation. Dr. Perez?
And I have to say, when we talk about provider versus diagnostician versus physician, that is where a lot of this stems from. The quarterback has to be in charge. The quarterback has got to feel that they have the power to move forward and to organize and to make the plays and carry the patient to the end zone where the touchdown occurs, right? That's what the quarterback has to make sure happens. And unfortunately, as we look in primary care, being a primary care provider as a pediatrician, many of those opportunities are 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 overwhelmed with administrative responsibilities without the time or the resources funneled into that direction. If we look at the amount of money that we're putting into case management by people who don't talk to each other and who are supposed to be doing or assisting the primary care provider in that type of quarterbacking, it's not working.
Okay, thank you for sharing. Any other comments about the presence or absence of a team and presence absence of a coordinator of that team or quarterback? Now,
Yeah, Dr. Perez mentioned about concierge medicine. Could you go into more detail about what exactly that is?
It's um, it's where you have a physician who will prioritize your calls, meaning they will get back to you within 3 to 4 hours of your call. They will coordinate your care, be in contact when you are hospitalized. Um, it's it's the physician that we had a generation ago. But now, along with your insurance, you're paying an additional $3,000 to $5,000 for this service. You usually have the cell phone number of your physician. So it's the way we used to provide care. And on the West Coast, in LA, there is a whole department of concierge medicine in UCLA. So it is becoming a specialty.
So in other words, it's a health care plan for the rich. If you got to pay $3,000 to $5,000 fee to get the top notch health care.
Correct.
Mhm.
On top of your insurance. Okay, so that and most of them don't take an advantage plan. You have to, because an advantage plan means that you're connected to the institution to which your plan is. So you are doing for Medicare, you have to have a supplemental plan and then the extra $3,000 to $5,000.
That's one form
That's
of it.
one form of it.
Yeah, because there are additional forms of concierge medicine. Uh, Gonna have Dr. Melanson talk to us about his version of how they use that in his transplant center. So I'll have him come and talk to us about that so you can have another version of the so-called concierge uh, practice. Janice?
Yes, my primary care doctor, a couple of years ago, he was trying to make a decision to go into concierge service. And he talked to me, so I'm assuming all of his patients, to get my viewpoint. As Dr. Perez said, definitely it's an expensive service. And he was given the dollar figures and even had a staff of people come to convince me. And again, I think he did it with everyone else. And I told him I was very satisfied with his service. He takes the time, he makes himself available. And if I had to pay the additional amount, I couldn't see where it would benefit me any more than what I'm getting now. He is I think, preparing to retire. He decided not to go to concierge service. He has reduced his hours as far as days of the week. But there's never been a time that I didn't go into his office and he didn't watch a clock. He took his time. He reminds me of my appointments. Remember, 3 months ago, you're supposed to do so and so. How's that coming? And, but I think all of his patients liked him. And I think most didn't agree to participate in the concierge service. So the outcome was he decided not to go into it. I don't know of anyone who has a doctor in the concierge business. But for me, like I said, with this doctor, I think he's given me all he can get, and I didn't need anything more. So something to think about if it's ever offered to you. Weigh it with the service you're getting, the service that they say they're going to provide.
Thank you very much for the discussion. I guess we can move on to the next article. This, this is an interesting article about a ketogenic diet improves the beta cell function more than low-fat diet in type 2 diabetes. And what you need to know is that the ketogenic diet is a diet that low carbohydrate, high fat, that results in the burning of fat rather than carbohydrate, which results in ketones being produced, which go to the brain. And this then is more desirable to the brain than glucose. And so this then results in better diabetic control. And though the ketogenic diet is not as popular as the carbohydrate diet, it's the diet that has revolutionized, for example, the control of epilepsy and things like that, and also revolutionized the way in which diabetes is controlled because the blood sugars are much lower, and therefore C-peptide becomes closer to normal. And this then is the diet that many people think is preferred over the traditional diet that emphasizes carbohydrate metabolism rather than fat metabolism. I don't know whether that makes sense to anybody, but that kind of is what this article is all about uh, having more fat in the diet and having less carbohydrate in the diet. And this is healthier in terms of uh, C-peptide or insulin use of the of the body by type 2 diabetes. I don't know, that may be confusing to many, but historically, uh, the ketogenic diet, or the diet that emphasizes fat, uh, was used traditionally to improve brain function uh, because glucose, as we learned from many studies, sugar and salt are two of the so-called poisons of the 21st century. And so the less sugar you have and the more fat you have, the better off it was thought for you to be. And so that's what this article is about, emphasizing uh, the breakdown of fat rather than the breakdown of glucose. John Buchanan?
I had a question, Dr. Callender, are potatoes considered carbohydrate?
Yes.
So on this diet, you would not eat French fries, right?
Well, there's not too many diets you would recommend French fries. But yeah, it's carbohydrate. Darryl?
Yeah, um, I say what fats are allowed on a ketogenic diet, and the fats that are recommended are healthy oils like virgin olive oil, avocado oil, coconut oil, but then you want to avoid seed oils like soybean, corn, and cottonseed. Those are be avoided. Um, there's fruit-based fats like avocados and olives, nuts and seeds like macadamia, walnuts, almonds, pistachios. They're allowed. Dairy is allowed with the ketogenic diet. And of course, it includes meats. It tries to avoid starchy food, and those are the root vegetables like potatoes, sweet potatoes, yams, peas, legumes. Uh, that's what's recommended to be avoided on a ketogenic diet.
Thank you, Darryl. for sharing. Any other comments? This is kind of advanced, but kind of helpful to understand uh, how we're moving away from salt and sugar and towards uh, fats being healthier in the long run. Any other comments about this article? If not, we'll go to the next one. This is an interesting article because uh, what this article does, it talks about breast cancer screening among women who are homeless. And it talks about the fact that in the United States, there's about 700,000 homeless people, which may well be an understatement. And uh, how do you deal with homelessness and trying to prevent breast cancer, colon cancer, and cervical cancer? And uh, what they found was that this intervention, which involves texting and navigating the homeless, resulted in uh, screening of breast cancer, which was effective, which was not effective for colon cancer or cervical cancer. And so, what is important is to recognize that you need a different strategy for controlling healthcare and those people who are homeless. And as the number of homeless is growing all the time and will probably increase as we have more of the Republican administration's elimination of Obamacare, uh, this is only going to get worse. And so interventions that are effective in the homeless become more and more important because um, those patients will not be able to go to healthcare facilities. And if they're not accepted there, they go to shelters and the management of the homeless and their health care becomes more and more of a concern uh, because as the numbers increase, the importance of having strategies to improve their care becomes very important. So to have a strategic plan or something that works for the homeless is important to identify. And they have identified this in this particular strategy for breast cancer screening. And so that's what this article is all about. That and as we address more and more patients who don't go to healthcare facilities but have no home to go to, this becomes a more and more uh, critical problem for us to address. And so this is one intervention that works. And so since they've identified this, they want to try to see uh, what other kind of models we can use to improve the healthcare in the homeless. That figure of $700,000, 700,000 people in America seems to me a bit low, but anyway, any of your comments about this subject? Darryl?
Um, okay, homeless women tend to have higher rates of obesity than their housed counterparts. If you're homeless, you're more likely to be 50% obese compared to if you live in a house, 42% obese. And uh, the obesity is directly related to cancer breast risks. So the homeless women being more obese are at greater risks of breast cancer. So everybody needs screening in the United States just because our obesity rates are higher than the rest of the world. but homeless women even more so.
Very well stated. Okay. All right. Any other comments about this? Because subsequent articles are going to reemphasize Darryl's points. Okay, if there's no more comments and questions.
And we're building a ballroom.
$250 million? Is that what it's going to cost? Something like that. Wow. Yeah, we are. Yeah. And we're hiding the homeless. Right. Yeah. So now this next article talks about strategies to catch cancer early in young adults. This is pointing out the fact that uh, people under 50 are getting more cancers than ever before. And how do we catch cancer in those young adults who uh, are 30 and 40? And this article talks about family history and getting genetic testing and educating young people to recognize the signs and symptoms of diseases uh, that occur in the 20s, the 30s, and the 40s. And one of the things they want to do is to talk more about the cancer symptoms which can occur in younger people, talk about genetic testing, talk about family history, and uh, identify high-risk groups that need to be ready to identify changes in bowel habits, changes in blood in the stool, any changes that allow you to make an earlier diagnosis of cancer, because by the time many of the symptoms occur, the disease becomes far advanced and not as easy to treat as it would otherwise. And so, uh, knowing your family history, knowing your genetic pool that you come from, all of these things become very critical as we are identifying that we are now getting cancer in much younger age groups than ever before, so that your children and grandchildren are more likely to have cancer before they reach the age of 50. And so, educating them and getting them to recognize early signs of cancers before they become late stage is important, and therefore knowing their family history is critical. Darryl?
Yeah, I wanted to do another plug for HPV vaccines, especially for children 9 to 14, where the vaccine is most effective, because that can show up as cancer in adulthood. The HPV related cancers affect a lot of the genital areas, and so like cervical cancer, penile cancer, vulva cancer, and so on.
Anal.
It's a group of cancers that, if you take the whole group, it's uh, it's right below it's right below prostate cancer as far as reported new rates of cancer. And for men, it expresses themselves in oral pharyngeal cancer, the throat cancer. For example, Michael Douglas uh, had that as a result of a HPV related cancer. So, um, that's something that's increasing, and it's very important that we get children vaccinated for HPV.
Especially the men or the young boys, yeah, because they're the ones who spread the disease. Yeah. Thank you for sharing. Very important information. Any other comments about how we protect our children and grandchildren from getting a late diagnosis of cancer? Carol?
Um, Dr. Perez, do the pediatricians prescribe this, tell the parents that this is one of the inoculations that they should get?
Absolutely.
Okay.
And the issue, I go back 20 years, was trying to convince parents that their children were going to be sexually active, because that's what you're preventing with this vaccine, the transmission, before they become sexually active. So the numbers have to get lower and lower, um, in terms of when the vaccine, it should become part of a regular schedule. And,
What age do
similar
you
to
think they
what
should,
we, huh?
what age do you think they should start getting the vaccine?
8, 5 to 8.
Yeah, right. Okay. Yeah, I think 9 is a little late.
Yeah. And, when they first started out, we weren't looking beyond, the 20s, but now the age has increased so that people in their 30s and 40s are being vaccinated against it. I think it is, with this administration and vaccines, it is definitely preventable. We we need to push for it, significantly.
Right, particularly emphasizing the
Young,
male population.
absolutely. And an opportunity, to discuss male sexuality, and lots of the issues that have come up, as it relates to the acting out behavior of men, um, and their inability to, control some other issues that are going on. So, yes, um,
How are they different from women?
the way we socialize men.
Hmm.
And I think that there is, a significant cultural, and though race is a social construct, I think, racial, issues need to be discussed from an ethical, standpoint. Um, um, Human trafficking is outrageous numbers. Um, and I think that we have to, as a society, look at that and address issues we were unwilling to address or look at as it related to, HIV disease. And many of the opportunities to prevent that transmission, I think, need to be more ubiquitous in our young adult population. So now that we have PrEP that's available, um, I think that we shouldn't wait to the event, but that we should try to prevent the event, and that we need to have more discussions about, about sex and what it means, and what's consent, what's not consent, what to expect, how I know I have learned, to ask children whether I can hug them, to become more sensitive, especially following, the COVID pandemic. Um, we we culturally have to do things differently than we did before. And our sexuality, I think, is a discussion, especially our community needs to have.
Carol, you had a comment?
Yeah, Dr. Perez, thank you so much. But one thing you told parents, and if you had told me as a young parent, and I'm raising my sons or daughter, and to give them inoculation because of sex, and they're 5 years old, I would told you, well, they just need to wait a minute, because my precious bambinos are never going to do anything like that. But that's a turn off. And one thing in our culture that we are always saying our boys can be promiscuous. They need to do that to be a man and keep your girls sheltered. And now the girls are saying they can also don't have to be virgins. Virgins are no longer have that highest thing of, especially boys are downrated if they are virgins and still teens. And girls, it's okay. So our culture, you have to think about what society is saying, even on television and etc. But I don't know how you go around it telling parents they need to get their kids inoculated, because if they're in preschool or early elementary, most parents like me, I wasn't completely naive, but we're also in denial that our child would ever do anything like that.
Okay. Any other comments about this article? And I think that one of the most important things is how the family looks upon the vaccines and whether they're really able to accept the fact that their children may be involved in sexual activity at the very young ages, and regardless of their feelings that their children should be vaccinated, especially the men. But the question is, with this administration, uh, how is the negative perspective about vaccines impacting the ability of the kids to get this very important vaccine? Okay, but I think that the idea of having the family discussion about the uh, family history and the importance of genetics becomes invaluable. Any other comments about this article and the strategy for uh, addressing these issues in the very young? A group for which early cancers was not as common as it is now, and whether or not it's related to the pollution that we are experiencing or to the many different products that we're exposed to, uh, as is suggested by many. Uh, One of the things we can do is to get our children and grandchildren educated earlier and get them knowledge about their family history and the importance of genetic testing. Okay, any other comments about this? Carol, is your hand still up or you have something else to say? No. Okay. All right, well, let's go to the next article. This is a kind of scary article about what we're doing about gun violence, that people who are in lower categories, who are poorer, or who are suicidal are searching up online about gun-related issues, particularly about how to kill themselves. And this is something that is scary. Uh, and what they are suggesting is that in these articles that they talk more about how you can safely uh, address having guns, because most of the articles are how you can inflict harm upon yourself and how you can kill yourself. And not how you can safely use guns. And so uh, it's very scary that people with mental health issues are searching more and more about how to use guns to harm themselves and harm others. Uh, how do we, for example, as families, do we discuss gun violence? Should we discuss gun violence? We have it every day, so uh, how can we not discuss it? Darryl?
Okay. The kids are searching for information on how to commit suicides with guns, and they're searching on either a smartphone, a tablet, or a computer. And these are children, and as parents have the ability to put parental restrictions on all those devices, which could block off. Um, we could parental restrictions could say you're allowed these sites where you can search, where you can use your whatever device it is, and that prevents the internet from being the wild wild west for kids, where they're in danger. But yet, you get parents that don't use the tools that are available for parental restrictions. It's a little different situation. If the kid doesn't have the ability to search for how to commit suicide using guns, if they don't have that ability, then you've at least taken away that threat. Not to say that you've eliminated all threats, but parental restrictions. And okay, the internet says that kids are smart. You restrict it, they may find a way around the restrictions, which means that if you give them devices, you have to monitor every week at a minimum to keep them in check. So we've got the ability, but it seems like parents are just more comfortable with letting their kids be in the wild, wild west.
And we are paying for it. Dr. Perez?
I did a little experiment around my grandson's first birthday, and that was asking people that I thought were a little a little younger than me, a lot younger than me, questions about their smartphones in the airport. Just little questions. I was surprised at how ignorant many people were about how to use their phones and their devices. I'm trying to get a cyber cafe at my church because so much is done with QR codes and go to this site to register for, the Brothers in Bacon on Saturday mornings and just different activities. And the level that many adults use, I don't think they know how to put all of the restrictions on their children. So that it takes a minute, and you don't do it to everything, you just do it to their ability to get onto different sites on their different devices. So I think it could be an educational point that's important. How to restrict, why to restrict here and there. And the platforms don't provide that for you. So, anyway, I think that there are a lot of parents who don't know how to do it. And that's why they don't have those restrictions.
That's right. And so if you don't know how to do it, your kid absolutely should not have any digital devices if you can't monitor it.
Uh, okay, well, it's 10:30 and I think the time is up. So we've had an interesting discussion and I think I spread the good news that Patty DeLone has had successful open heart surgery and she's recovering at home. And so we continue to pray for her complete recovery. But so far, so good. And thank you for attending today. And God willing, see you next week.
Thank you. Thank you.
Okay. All right. Bye.
Bye, family. Love you.
Bye. See you next
Bye.
week.
Bye. God bless.
So,
Oh, I wonder where Betty was today.